Our job is really, to provide the best care possible for those patients, or they're going to be in the best position to sustain the rigor of any type of intervention that we're going to do. The problem is there is very, very little evidence. And not only that, but there is a lot of practice variations depending on where you train or where you are located. What's available to you. I can give you the best regimen based on what we have right now, but you go home and either your local providers cannot find what you need, or you cannot afford to get it. Cost is a huge issue. I'm actually so pleased that Lotus has put together those cost analysis, because it's really staggering the amount of money that you require, to take care of an EB patient, and I think it's very important to continue to advocate that. And ultimately, the family preference. Again, as a physician or a nurse, we can come up with a plan that we think makes sense for us, or based on, on the evidence that we have so far. But a lot of the families have time-tested routines that are very hard to change, and it may work the best for their patients. So one of the first lessons I've learned when I started the clinic in Toronto in 2004 is that you have to listen to with your families, and it's more of a dialogue rather than a monologue. So evidence-based medicine, this is what we are trained, to try to have as a goal when we're talking about anything we do in medicine. So this is a pyramid, which you can see starts at the bottom with where, unfortunately, we are still in a, let me see, we're still are in the EB era. We're still at kind of expert opinion. It's my opinion, your opinion, and so on. Very few case series and case reports when it comes to wound care. Unfortunately, there are no cohort studies, but we're hoping to change that, and we're not even close to randomized control trials. So we have a long way to go when it comes to actual evidence in medicine. So is expert opinion always equating consensus? And I definitely, I don't think it's the case, but at least we can agree to disagree in many respects. So based on the lack of evidence for anything we're doing in clinical practice, I decided to, together with my colleague from Toronto, Dr. Siebold, who is a world care expert, to put together a consensus meeting to try to at least to tackle a little bit this problem. So the consensus meeting happened in Alton. It's a lovely city next to Toronto, about an hour away, in actually a year ago, June 2011. So we put together a list of recommendations. Based on those recommendations, we sent it to 33 specialists that we felt, both nursing, other healthcare professionals, and physicians. And to get their input, which of the item we should keep or not. And we decided before sending it that we're going to keep everything that had more than 80% agreement. And then whatever was left, we subdivided into teams and specific recommendations. So this is the lively city of Alton. We had 11 attendees with international representation, and we had EB specialists from both adult and pediatrics, wound care practitioners, wound care scientists, because we really need to understand more about the science behind the stuff that we do, nursing, PT, infectious disease, and bone marrow transplant. Sorry. So the survey was sent, as I said, to 33 EB experts, and we had only 15 responses. But what was interesting is that in terms of the EB care expertise, over 60% of them had more than 15 years in working in the EB area. So obviously we had a very good representations, and most of them were MDs, but we had nursing as well as other healthcare professionals. And many of the people who replied are in this room, so thank you very much for participating. This is a busy slide. I'm just emphasizing the percent consensus, and you can see most of the items is in this column here. They're all way above the cutoff of 80 that we said, and it's the same here. So a lot of them were 100% or above 86, I think was the lowest. So the final product were 17 specific recommendations that were subdivided in 5 domains, and this was published this year in the JAD. And the framework of what we've done is more of a holistic approach to wound care in EB. So the 5 domains that we identified were assess the patient's ability to heal. And I'm going to go back to describe this a little bit more. Provide the local wound care, develop individual wound care and a care plan, provide education support, but at the core, in the middle of all this, is the patient-centered concern. So unless you address some of those, all the stuff that we're talking about is not going to have a lot of impact. So let's go through the first one, assess ability to heal. We all know that the EB-specific involvement determines the extent of the wound care. So this is a patient with Dowling-Meara type of EB simplex. Obviously, this type of patient requires very different wound care than a patient with, for example, junctional EB. And it's not only the extent that we're talking about. It's probably, we have to challenge even the classical care that we provide in terms of wound care. So for example, a lot of Dowling-Meara patients will tell you, or families will tell you, that keeping the wounds dry works better for them than keeping them moist, which is kind of the classical teaching that we have when we're dealing with chronic wounds. So obviously we need to kind of explore that further to understand why that happens. This is a patient with junctional, and you can see those, what I call crater-like wounds, chronic wounds. There is a lot of inflammation there. Unless you deal with that kind of inflammation, you're not going to be able to heal those. How about the age of the patient? Again, there are comorbidities associated with older age. So there is a risk of trauma. As you go further along in your age, you also become colonized and critically colonized with resistant bugs. That is important. And what's the feasibility of following a certain regimen? If you're trying to go to 10 classes every day, you actually have to be flexible about the type of dressings that you're going to do. I think at the cornerstone of, or the difficulty of doing wound care is the chronic wounds. That's what we're basically struggling with. So chronic wounds lead to blood loss that leads to anemia. Anemia by, basically, again, kind of perpetuates a chronic wound, and I'll go back to that in a second. Chronic wounds also lead to protein loss, low albumin. But the low albumin is also caused by a lot of the mouse problem that we talked about and the GI problems. And low albumin, you need a lot of protein in order to heal. So you can see everything is becoming a circle here. Chronic wounds also lead to colonization and infection. And that also interferes with, causes local and systemic inflammation. And the inflammation, again, prevents wound from healing. So unless you actually address some of those, we're going to go in circle over and over. So that's why it's important to address the nutritional status, which we discussed about. And from some of the older literature, you need a protein of over 3 grams per liter in order to heal. And not many, as you know, not many of you have actual protein levels drawn. But I can bet, that you can see, once your protein level go higher, you can actually notice more healing. We need to monitor the growth curves and BMIs. And again, we advocate for early insertion of a G-tube just to maintain, those high caloric requirements. We talked about the hemoglobin. There is actually one paper that looks at the level of hemoglobin that is associated with good healing. And the cutoff is 100. I think that's a goal that is not really achievable by many of you, particularly with the severe forms of EB. But you need a minimum of 80 to actually achieve some sort of, to help your healing. And one thing is actually to prevent bleeding as much as possible, but also to treat. And Dr. Brackner talked about it yesterday. How about pain management? Again, you know, there are actually a lot of tables in the paper that talks about preventative and therapeutic interventions. And again, I'm not going to go more into this, but emphasizing the fact that you have to explore both pharmacological and non-pharmacological interventions, as was talked about yesterday. Itch control. Assess timing, frequency, and precipitating factors. There are many of our patients who go through periods where they have intense itch, and you really have to go to the basis. Any single change in their skin routine may be associated with that. Sometimes just a change in the topical routine might be the thing that will make a difference. And again, we talked about yesterday that there isn't an ideal medication, but we recommend it based on what was their sedating agents for the nighttime and non-sedating for the daytime. How about patient-centered concerns? This is a huge issue. It doesn't matter what I tell you to do. If it doesn't make any difference for you, it's not gonna work, and you know, probably a lot of the patients are not gonna comply. So we need to figure out how is the dressing or the recommended regimen gonna fit into the activities of daily livings. What's the degree of mobility that you're trying to do? What's the degree of independence? Are there any special needs? How many of you are in wheelchair? Is that gonna change the dressings that we're gonna put in the buttock area? And what kind of social interactions? Are you going to school every day? Are you trying to attend work? Is the smell a big issue, and do we need to deal with that? Provide education and support, again, to the patient, to the family, and the extended circle of care. There are a lot of practitioners, physicians, nursing, and so on who feel overwhelmed when they're dealing with EB patients, and rightly so. I was overwhelmed when I started, and I think it's only by developing a network of people who actually talk the same language, have the same goal as you, that's the only way you can actually feel supported. Again, I emphasize that this is dialogue and not a monologue. It's very important, you know, to feed back to your physicians or nursing, you know, what works for you and doesn't work, without feeling that you're overstepping your boundaries. And most of us will listen. How about wound care? So the 6 steps that we thought are important is to assess the wound location and characteristics, and I'll get back to that in a second. Cleansing and debridement, assessing and treating critical colonization and infection, topical and systemic care, edge effect, and I'll go back to that, and ultimately expected rate of healing. You know, we have to have some goals when you look at that. So wound location and characteristics, it's kind of easy to look at the extent and to kind of ask yourself, is it an acute, chronic, or a non-healing wound? And we came up with this algorithm called MEASURE. It's actually borrowed from the wound literature. Dr. Siebold coined the terminology, and we kind of modified it for EB patients, but it's an easy algorithm for practitioners to follow. So MEASURE means size, you know, so just measure the extent. Exudate, so it's very important to actually elicit the type of exudate that is there. Is it red, clear? Is it yellowish? Is it green? What's the appearance of the base? So there's a lot of literature, particularly in the chronic wound literature, that tells you the base tells you a lot about it. Suffering is the pain associated, and that's something that you have to tell us. You know, how painful is it? Reevaluate, meaning, you know, you have to, if you've seen it today, you know, you have to have some expectation of how much healing is going to occur, and if it doesn't happen, you have to think about why. And the edge effect, which I'm going to come back in a second, is also important. This is a table. It's not meant to be read, but what we came up with, you know, based on the type of wound, we came up with the type of primary dressing that is recommended, secondary dressing, and others. And we try to combine the dressings that are available all over the world. So, and you know, more in one category, so you can customize it according to your needs. Cleansing and debridement, not a lot of evidence out there, but we all agree that you need a non-toxic solution. So saline is good, water is good. They have in UK dermal range. You can order on the internet. They swear by it because it's supposed to actually, it's very well tolerated. It's supposed to do a very good job of cleaning a lot of the bacterial load. We learned from you that soaking in salt, a lot of it, is actually helpful. And you can add bleach or acetic acid, which is vinegar, for Pseudomonas infection. There is Dr. Siebold, who has a lot of experience in this area, is not very favorable to bleach because apparently bleach can actually prevent healing as well. But I think in small doses, and you can gauge that, it's actually helpful. And debridement really refers to what we usually teach you. Try to release the fluid from the blister, and if there is a lot of dead tissue, that needs to be taken off as gently as possible. And we usually recommend not a physical removal of dead tissue, but actually either soaking or putting some hydrogel, for example, something that is going to hydrate and allow the crust to fall off. The idea is that if you leave that hemorrhagic, crustic, or necrotic lesion, the wound is not going to heal on top of it. So you just need a clear base in order to heal. How about assessing critical colonization and infection? Just a word about what we mean by critical colonization. All of us, including ourselves who don't have EB, are colonized with bacteria on a daily basis. When you have chronic wounds, it comes to the point when the normal bacteria, or the ones that are beneficial for you, are outweighed by the ones that are more damaging to you. And that's called colonization. Now, critical colonization means you have so many of them that actually stops the healing process. And there is a number that we use in terms of colonies and so on. If that goes long enough, you actually become infected. So you have the discharge smells, you have a lot of pain, and so on. And again, Dr. Siebold came up with those two acronyms, NERDS and STONIES. So what that refers to, NERDS refers to critical colonization. So then you have a non-healing wound, a lot of exudate, red bleeding, hemorrhagic. So you've seen those, the granulation tissue is very red, beefy red. You have a lot of debris, so a lot of stuff, and you have smell. And doesn't project well, but this is a wound that will qualify to that. And if you have that, if you have 3 NERDs, you need topical antibiotics. And this is not something that we routinely recommend because you don't want to select bacteria that are resistant. Now, stonies means infection. So in addition to what you see there, the size gets bigger. So despite what we're doing, not only that it's healing, but it gets bigger. You have a local increase in temperature of more than 3 degrees Fahrenheit. You can actually probe to the bone, which hopefully we don't see in any of our patients, but sometimes it happens. You have new breakdown in other areas. You have all this, evidence of inflammation, exudation, edema, erythema, and obviously the smell. So, this is a wound again. You can probably, but you see the exudate is much more impressive there. And if you have 3 stonies, you need systemic antibiotics. The reason we don't use culture as a way of dictating the treatment is because we're all colonized. We are colonized, so we're not going to be able to differentiate, this is the bacteria that is causing this, unless you do a biopsy, which we don't necessarily do. So you have to kind of rely on those soft clinical findings to help you. Select appropriate dressings and topical care. So I think I emphasized that you need to individualize the treatment. But not only that, in the same patient, you have multiple types of wounds. So you may have a dry wound, you may have an exudative wound, you may have a chronic non-healing wound. So you actually need, in the same patient, to change the dressing that you're using. You can apply the same thing to all the patients. Think about availability and cost, and also the patient preference. This is an important thing. Unfortunately, we don't have any data in EB, but from the wound care, you expect about 20 to 40% shrinkage of the wound if you did everything right at 4 weeks. And that indicates healing at 12 weeks. Now, some of you may know that you have chronic wounds that you had there for years, so it's kind of hard to put your head around those numbers. But I think it's important as a goal that if things don't change, you're missing something. Either the inflammation is not controlled, the infection is not controlled, you're using the wrong medication, or maybe the patient is not doing what they're supposed to do. This is very important, wound edge. So this is the rocky coast, and I emphasize this because those are the wounds that do not heal. So as you can imagine with this, the water, which is imagined as the level of the skin that where it needs to go, has a lot of way to go to reach that point, and that's a wound, what the wound would look like. So you have a lot more to work on this wound in order to get to the point. In contrast, this is the sandy shore, so the superficial wounds that that they're going to heal. So it's important to assess that wound age because that's going to tell you, the healing or not. Very important. Biopsy suspicious areas. Listen to your patients. If you feel that the wound is different, if you find things that do not heal in the expected time, you need to biopsy, and you need to do multiple biopsy. Tailor and reassess. Flexible approach, very, very important. Make sure that this is distributed to the circle of care. It's not enough to have an agreement with the family that this is what you're going to follow. It's important that, the home care, that's what we deal with in Canada, not very successfully most of the time, the family practitioner and so on, everybody is on the same page and they understand that this is what needs to happen. Update periodically, things change, are very fluid. Consider a support structure. So referral to a specialized clinic. I think most of you, since you're here, you probably are aware of those. Reaching out to experts. I do this all the time. I'm sure don't be afraid to be your own advocate. If things don't work well, just ask your doctor to send you somewhere else. Reach out to organizational support, and DebRA, as we all know, is a great support. So where do we move from here? I went very briefly through those 17 recommendations that came. What we need, the next step will be to actually go into each specific recommendation and try to make it in such a way that we all agree upon. There are other attempts to generalize guidelines for wound care, probably not as comprehensive as ours because they tailor just the wound care part. The skin care, but the goal is actually for the upcoming DebRA Congress is to harmonize those other attempts. So there's a UK attempt, an Italy attempt, and hopefully we can have something that we can all agree upon. My main worry is that we come up with those very nice proposals or guidelines, but they're going to be not followed because they're not going to have access to the right care. So one of my goals is also to try to develop an EB care kit for underdeveloped countries. The reality is that not everybody is going to have Mepilex and Mepitel and all the other wonderful things that we use. And we need to recognize that there is a lot of other people out there that are suffering without actually access to even close to what we have here. So I want to leave you with a poem of one of my favorite patients for two reasons. One is because she was the inspiration to start the EB clinic back in 2004 in Toronto. The other thing is because all of you have a lot more to say than you think you have right now. And don't give up, speak loud, try to reach to other people. So I'm going to read the poem with you. There are only fragments of it. I'm thankful to live in a time where women are given opportunities, where theoretically we're equal, where there is knowledge of my disability, where I don't have to be alone in this disease, where my future is not predetermined because of my race, because I'm disabled, or because I am a woman. Though I know we still have miles to go before we get to true equality, but at least we're on the road that leads in that direction. Each of us, in a small or large way, affects an individual life. Each decision takes us on a different course and leads to a different path. Fear blocks progress, fear of unknown, unseen, unheard of, unchanged. It is a shame to throw away an opportunity because many people in the design mapped out that change. sorry. I'm thankful to be born on the train of life marked 1985, for without its ticket, I wouldn't be living this life. And this is Novelette's work. Thank you.
Dealing with the edge effect, did you say that when you have the edge that's down low like the ocean would be, and then up where the top of the skin actually is like the rocky cliff, and some of those that he has are very ongoing since I started working with him 3 years ago. Is that something that should be addressed, or because they're chronic and they've been like that for 3 years, that's life of EB?
Yeah, so I think, you know, basically we need to look what's at the bottom of the cliff.
Red, pulpy.
Yeah, so that's probably the first thing we need to do. I suspect that there is a lot of bacterial overgrowth there that will need to be addressed. The significance of the edge effect is that you're going to have a wound that takes a lot longer to heal than the flat one, which is, you know, it's understandable. But you need to put in place all the other, you know, things that I said, you know, try to minimize the inflammation, try to minimize the infection. Sometimes you might just need to pack that. If it's deep enough, you might just need to pack it with a dressing that has some antimicrobial and allow the healing to occur from the bottom up. And then, you know, things will get better. It's a slow, and the other significance of the edge effect is if it's been there for a long time, I would want somebody to have a look to make sure we're not missing something else.
We have chance for 1 or 2 more questions.
Okay, could you please repeat what you said, something about keeping the wound dry versus keeping it moisture, and you talked about this,
Downley era. So the classical teaching in wound care is that in order for a wound to heal, you have to keep it moist. So the moisture usually is provided by the dressings. So you have to cover it, keep it moist, and then it heals. What we've learned from our patients is that the kids with Dowling Miara heal faster if you leave them to dry out. So the less dressings, the better. So what they usually do, and I've seen it in UK, my colleague Gemma Melerio actually uses it quite a bit, is they pop the blisters open and they actually sprinkle cornstarch. And that actually dries them out quite a bit because draws some of the fluid out, and they heal much faster that way. Sometimes you may get to the point that, you know, the blisters, the crust become quite, you know, big and so on. So then you have to soak them a little bit to get rid of them. But, you know, immediately it's actually probably better, and a lot of our patients say that it's better for them to leave them, you know, to dry on their own, or to than to put a dressing on top. I was just going to make one announcement. After lunch, I'm hosting a special session on developing a severity score for epidermolysis bullosa. All the physicians and non-physicians that are interested to participate, they're welcome to. The room is Emerald Room A. So you go on your left, go the elevator down, and it's the first conference room. So thank you.